Hello, everyone. In this lesson, we're going to discuss hematologic system disorders. We're going to review the structure and function of blood, common hematologic conditions such as anemia, leukemia, and coagulation disorders, along with diagnostics, treatments, and important clinical implications. As we go through the lecture, try to connect the pathophysiology to the patient's symptoms you would actually see in clinical practice, because hematologic disorders often affect oxygen delivery, immunity, clotting, and they impact every body system. Please complete your assigned readings in the module and look at your key points and complete your study guide as you are listening to this lecture. So these are the learning objectives for this lesson. So the hematologic system has a few roles. Why is it important? Right? It is essential for survival because it supports oxygen delivery, nutrients, and waste removal, immunity, and clotting. Red blood cells, RBCs, transport oxygen to the tissues. White blood cells, WBCs, help protect us from infection. Platelets and clotting factors prevent excessive bleeding. Blood also helps regulate body temperature, maintain acid-base balance, and homeostasis. So now when something goes wrong in the system, patients may present with fatigue, bleeding, infections, hypoxia, or organ dysfunction because the hematologic system has so many different roles in so many different areas of the functioning of the body. On this slide, we're going to review the three major types of blood vessels. And this is an anatomy concept, so it's something that you should already be familiar with. You have arteries, veins, and capillaries. Each vessel type has specialized structure and function that helps maintain circulation and tissue perfusion throughout the body. So the arteries carry blood away from the heart. Because blood is pumped out under high pressure, arteries have thick, muscular, elastic walls that can withstand that pressure. Most arteries carry oxygenated blood, with the exception of the pulmonary arteries. Arteries are considered high pressure system and help maintain blood pressure and tissue perfusion. Now let's look at the veins. Veins carry blood back to the heart. Unlike arteries, veins are low pressure. They're a low pressure system and have thinner walls with less muscle. One very important feature of veins is that the presence of valves. These valves prevent blood from flowing backward, especially in the extremities where blood has to travel against gravity. Another key important point is veins hold about 70% of the body's volume, making them a major blood reservoir. Finally, we have the capillaries. Capillaries are the smallest blood vessels and are only 1 cell thick, literally. Their thin walls allow substances to move between the blood and tissues through diffusions. Capillaries are the main exchange site for oxygen, nutrients, CO2, and waste products. This is where the actual delivery of oxygen, nutrients to the tissues occurs. At the bottom of the slide, you can see a quick comparison. Arteries, high pressure, thick walls, carry blood away from the heart. Veins, low pressure, contain valves, carry blood toward the heart. Capillaries, exchange vessels with very thin walls. One helpful trick is arteriozoe, carries blood away from the heart. Understanding these vessel differences is important because many of the cardiovascular and hematologic disorders that we are going to cover affect circulation, perfusion, clotting, and blood flow through these vessels. Blood has several critical functions. It transports oxygen and nutrients like glucose to the cells and removes waste products such as carbon dioxide. Blood also carries antibodies and immune cells that help fight infection. It helps regulate pH and body temperature and plays a major role in clotting and hemostasis. Remember, hemostasis, super important, and now remember the difference between homeostasis and hemostasis, and we're going to talk more about that because hemostasis has to do with clotting. Homeostasis is internal balance. One easy way to remember this is to think of blood as the body's transportation and defense system. The average adult has about 5 liters of blood, which makes up approximately 8% of the body weight. Blood consists of plasma and formed elements. Plasma makes up about 55% of the blood and contains water, electrolytes, proteins, nutrients, waste products. Formed elements make up about 45% and include red blood cells, white blood cells, and platelets. Important plasma proteins include albumin, globulins, and fibrinogen. Albumin helps maintain osmotic pressure, as we discussed even in our fluid and electrolyte lecture. Globulins assist with immune defense and transport, and fibrinogen is critical for clot formation. So, all of these are very important. They all play very important roles in maintaining, hemostasis. So, this slide compares red blood cells and white blood cells and highlights their major functions in the body. So, please take some time to review this and print it out however you want to do it. It's very important information that's going to help you understand the disease processes that we're going to cover. So red blood cells, RBCs, are flexible biconcave discs that contain hemoglobin, and they have a lifespan of about 120 days. Their biconcave shape increases surface area for oxygen exchange. Hemoglobin is a protein responsible for carrying oxygen. When oxygen is attached, it's called oxyhemoglobin and appears bright red. When oxygen is released, remember it delivers oxygen to the tissue, so when the oxygen is released, it becomes deoxyhemoglobin and appears darker red or bluish. Old RBCs break down mainly in the spleen and liver. Iron is recycled and reused, while bilirubin is excreted in the bile. Excess bilirubin can lead to things such as jaundice, which causes the yellowing of the skin and eyes. Right? The major function of RBCs is transportation of oxygen to tissues and carrying carbon dioxide back to the lungs. Now let's look at white blood cells, or WBCs. Their main role is protecting the body from infection, inflammation, and from foreign invaders. There are two major categories of WBCs. You have granulocytes, which include neutrophils, eosinophils, and basophils, and then you have agranulocytes, which include monocytes and lymphocytes. Neutrophils are the first responders to bacterial infections. Eosinophils are involved in allergies and parasitic infections. For example, people with high allergies usually have a high count of eosinophils. Basophils release histamine and heparin during inflammatory processes. Monocytes become macrophages and perform phagocytosis, which we talked about in our lymphatic lecture. Lymphocytes are critical for immune responses and include B cells, T cells, and NK cells. So overall, RBCs mainly transport oxygen, and WBCs mainly defend the body. Hematopoiesis is the process of the blood cell production. All blood cells originate from the pluripotent stem cell in the red bone marrow. In adults, red bone marrow is located in the pelvis, sternum, ribs, and vertebrae. An important hormone involved in RBC production is erythropoietin, which is released by the kidneys in response to hypoxia. This stimulates the bone marrow to increase red blood cell production. And that is the reason why patients who have kidney disease often develop anemia, because they're not producing enough erythropoietin. And so patients who have kidney disease, who are on dialysis, we tend to give them erythropoietin to help with that blood, production. Platelets, also called thrombocytes, are essential for hemostasis and clot formation. The normal platelet count ranges from about 150,000 to 400,000. Hemostasis occurs in several steps. First, you have vasoconstriction, reduces blood flow to the injured area, right? Second, platelets form a temporary plug. Third, the coagulation cascade produces fibrin, which stabilizes the clot. Clotting factors are basically produced primarily by the liver, and many are vitamin K dependent. The body also has anticoagulant mechanisms like protein C and antithrombin to prevent excessive clotting. Finally, fibrinolysis breaks down clots after healing occurs. So these are all very important key terms and concepts you need to understand in order to understand disease processes that you're going to cover, in nursing school or just in our pathophysiology class that we're going to cover in a few slides. Okay, blood dyscrasias, what are these? These are abnormalities in blood composition or function. Common examples are anemia, leukemia, coagulation disorders, thrombocytopenia. These disorders may affect oxygen delivery, immune function, or clotting ability. Many patients present with nonspecific symptoms such as fatigue, weakness, bruising, or infection. So lab testing becomes extremely important because just from those symptoms, you're not going to know that they have a blood dyscrasia. So let's talk about these blood dyscrasias. One is anemia. Anemia is defined as the reduction in hemoglobin that impairs oxygen transport to tissue. Because remember, what does hemoglobin carry? Oxygen. So if a person does not have enough hemoglobin, then they're not going to carry enough oxygen to the tissues. So this is extremely, this is extremely important because the patient will become hypoxic. Anemias are basically classified based on the size and appearance of those red blood cells or the mechanism of disease. For example, if you look down here, based on, the MCV, you have microlytic, less than 80. This is the quantity of how much, red blood cells there are. Normocytic and macrocytic. So these are, categories that are used to classify the severity of anemia. These are the different types of anemia. Let's basically, very briefly, review the major types. Iron deficiency anemia is the most common type and results in microcytic, hypochromic cells due to decreased hemoglobin production. Pernicious anemia results from vitamin B12 deficiency caused by a lack of the intrinsic factor and produces large immature red blood cells, right? So they're not mature enough to carry enough oxygen. Neurologic symptoms are common in this type of anemia. Aplastic anemia occurs when the bone marrow fails, leading to pancytopenia. These patients are at risk for infection, bleeding, and severe fatigue because they're not getting enough oxygen. Hemolytic anemia results from excessive RBC destruction. So the RBCs are being produced, but they're being destroyed and commonly causes jaundice. Sickle cell anemia is caused by abnormal hemoglobin and low oxygen, causing the RBCs to sickle, leading to vaso-occlusive crisis and tissue ischemia. So basically in sickle cell anemia, because they're not formed properly, they're sickled, they can't carry enough oxygen and causing ischemia. Thalassemia is a genetic disorder. This involves defective globin chain production and can range from mild to severe. There's a chart here I created. Please review this. It explains the patho of each of the type of anemia, the etiology, basically the causes, and what symptoms you usually see in each type. This is a cheat sheet with all the types of anemia on it. Hopefully it will make it easier for you to remember this. Now let's talk about leukemia. Leukemia is a cancer of the blood forming tissues characterized by uncontrolled proliferation of abnormal white blood cells in the bone marrow, right? As leukemic cells multiply, they crowd out normal blood cell production. This causes anemia from decreased red blood cells, thrombocytopenia from decreased platelets, and functional immunosuppression because abnormal WBCs do not function properly. So basically, you're immunosuppressed, you have decreased platelets and decreased RBCs. The Philadelphia chromosome is an important genetic abnormality seen in many cases of chronic myelogenous leukemia or CML. This mutation drives uncontrolled cell growth. Like remember, even in cancer, it's a type of a cancer, so it's uncontrolled growth, Leukemia can be classified as acute or chronic. Acute leukemias involve immature blast cells and progress rapidly. Chronic leukemias involve more mature cells and progress more slowly. So leukemia cells can infiltrate organs such as the spleen, liver, lymph nodes, and the central nervous system. Patients can develop splenomegaly, bone pain, hyperuricemia, too much, acid in the urine, and then headaches and neurologic symptoms. Diagnosis often involves doing a CBC, some blood work, right? Abnormalities and confirmation through bone marrow biopsy. Here is a cheat sheet with all of this information. Please print it out or download it so you can use that to review leukemias. Now let's talk about coagulation disorders. These occur when platelets and clotting factors are both abnormal. In the first one we're going to talk about is ITP, right? And this involves autoimmune destruction of platelets, increasing blood risk. Then we have TTP, thrombocytopenia. This causes the platelets to clump into small vessels and leads to thrombus formation and organ damage. Then you have heparin-induced thrombocytopenia. This is an immune reaction to heparin that paradoxically causes clotting despite low platelets. Then you have drug-induced thrombocytopenia as well. This is basically thrombocytopenia caused by a drug. Now let's talk about hemophilia. Hemophilia basically involves missing clotting factors, factor 8 in hemophilia A and factor 9 in hemophilia B. Then you have von Willebrand disease. This affects platelet adhesion, so they don't adhere. And then we have DIC, disseminated intravascular coagulation. So this is especially important because it causes both clotting and bleeding simultaneously. So microclots consume platelets and clotting factors, leading to severe hemorrhage. So you're both basically clotting and bleeding at the same time. Here is a cheat sheet on the different types of thrombocytopenia, their causes, mechanisms, and consequences, clinical manifestations that you're going to see. Please download this or print it so you can use this to review. So basically, thrombocytopenia refers to platelet count below 100,000 per microliter. Although normal platelet count ranges from about 150 to 400,000, there are three major mechanisms: decreased platelet production, increased platelet destruction, or increased consumption or sequestration. Decreased production often occurs in bone marrow disorders such as leukemia, plastic anemia, or chemotherapy-induced marrow suppression. Increased destruction occurs in disorders like thrombocytopenias like the ITP, TTP, HIT. In these conditions, platelets are destroyed or consumed faster than they can be produced. Increased consumption occurs in DIC, where widespread clotting exhausts the platelets and clotting factors. Platelets also become trapped in an enlarged spleen called a splenic sequestration. Clinically, thrombocytopenia primarily increases bleeding risk. Patients can develop petechiae, the small spots, purple red spots, purpura, ecchymosis, mucosal bleeding, or life-threatening hemorrhage if counts become severely low. Always monitor thrombocytopenic patients carefully for these signs of bleeding. It's extremely important. Clotting factor disorders, primarily hemophilia and von Willebrand disease. Hemophilia is an inherited X-linked recessive disorder. Hemophilia, you have A and B. And then you have without these clotting factors, basically the coagulation cascade cannot complete, meaning a stable fibrin clot cannot form properly. So you basically will bleed, right? These patients often experience spontaneous bleeding into joints called hemarthrosis, as well as prolonged bleeding after minor trauma or procedures. Now comparing von Willebrand disease, which is the most common inherited bleeding disorder. This factor helps platelets stick to injured blood vessel walls. When VWF is deficient or defective, platelet adhesion becomes impaired. So this can cause poor clot formation, and basically patients will experience easy bruising, nosebleeds, heavy menstrual bleeding, prolonged bleeding after surgery or injury. The big difference here is hemophilia involves clotting factor deficiencies, and VWF, the von Willebrand disease, VWD, involves impaired platelet adhesion. So it's either involves clotting factor deficiencies, factors that help create clots, or the sticking of the clots together, the adhesion of those clots. Let's talk about the diagnostics and treatment of anemias, the blood dyscrasias. So here's a cheat sheet created for the diagnostic methods for hematologic disorders. Basically, it summarizes all the major diagnostic methods used to diagnose hematologic disorders. You have your CBC. It's the first line testing, golden standard. It evaluates RBCs, WBCs, hemoglobin, hematocrit, and platelets. It helps identify anemia, infection, bleeding disorders, and malignancies. RBC indices help classify anemia. So MCV tells us the cell size. MCH and MCHC evaluate the hemoglobin content, basically how much oxygen-rich blood there is in the red blood cells. Reticulocyte count tells us whether the bone marrow is responding appropriately. Specialized anemia diagnostic tests include iron studies for iron deficiency, hemoglobin electrophoresis for sickle cell disease and thalassemia, Schilling's test for pernicious anemia, FOBT, fecal occult blood test to identify any GI bleeding to see if there's any blood in the feces. Coagulation studies assess clotting function and include platelet counts, PT-INRs, APTT, D-dimer testing. Then you have bone marrow aspiration biopsies. These are critical for diagnosing leukemia because remember it's a type of cancer, aplastic anemia, and marrow disorders. These procedures allow providers to directly examine the blood-forming tissue. Advanced testing such as cytogenetics and flow cytometry help identify specific malignancies and genetic mutations like the Philadelphia chromosome in CML. The key point is that hematologic disorders are often diagnosed through a combination of lab values, imaging, tissue biopsies, and molecular testing. This cheat sheet kind of summarizes all of those. Then this is basically a description of the CBC and RBC findings. Please look over this. There's a lot of important information over here. These are different coagulation studies. We have the PT, INR, you have the International Normalized Ratio, which is the INR, you have PT, you have APTT and D-dimer. Please read over these. These are important to remember. Now let's talk about, that was diagnostics. Now let's talk about the treatment for hematologic pathologies, right? So treatment for anemia focus on restoring oxygen carrying capacity. Okay, if you don't have enough hemoglobin, we got to make sure oxygen gets to the tissues. Iron deficiency anemia is treated with iron supplementation, often in vitamin C to improve iron absorption as well. Pernicious anemia requires lifelong vitamin B12 replacement because remember it's a vitamin B12 deficiency because the intrinsic factor is lacking. Aplastic anemia may require blood transfusions, antibiotics, bone marrow stimulants, or stem cell transportation because the marrow has failed. Sickle cell anemia management focus on preventing vaso-occlusive crisis by avoiding dehydration and hypoxia because remember they're sickled cells and so they can cause huge clots and we want to make sure that the patient is not dehydrated, because you want to keep that blood flowing and hydrated. Blood transfusions and bone marrow transplantation may also be used for sickle cell anemia. For coagulation disorders, treatments vary based on the cause. ITP is treated with corticosteroids and immunosuppressants. TTP is treated with plasmapheresis. HIT requires, if it's heparin induced, the first thing you want to do is discontinue the heparin. Hemophilias requires clotting factor replacement, and in DIC, remember that's the one with the disseminated intravascular, basically bleeding and clotting at the same time. The priority is treating the underlying cause while replacing clotting components such as platelets and fresh frozen plasma. Hematologic malignancies like leukemia, they often require chemotherapy, radiation, targeted biologics, monoclonal antibodies, or stem cell transplantation. Now, one major concept to remember is that treatment often targets both symptoms and the underlying pathophysiology. Now let's real quick talk about blood types. This slide basically covers ABO blood group systems and the Rh factor. Blood type is basically determined by antigens located on the surface of the red blood cells. The plasma contains antibodies against antigens in the body that the body does not recognize. Type A blood has antigens, A antigens, and B antibodies. Type B has B antigens and A antibodies. Type AB has both antigens, but it has no antibodies. That means it's the universal recipient. So you can give them whatever kind of blood, and they're basically the universal recipient. Type O has no antigens, but has both antibodies, making O negative, the universal donor. So basically, you can give type O blood to most people. The Rh system depends on the presence or absence of the Rh antigen. Rh positive means the antigen is present, Rh negative means it's absent. So Rh incompatibility can lead to transfusion reactions or hemolytic disease of the newborn. One key concept to remember: antibodies attack what the body sees as foreign. That's why matching blood types correctly is so important, or else when the patient is getting a blood transfusion, the body starts to attack its cells. So the ABO and Rh blood groups often systems are critical for safe transfusions. Rh positive individuals have the Rh antigen, while Rh negative individuals do not. So an Rh negative patient should generally not receive Rh positive blood, because this exposure can trigger antibody formation. And future exposure then can lead to hemolysis, explosion of the blood clots, of blood cells, and transfusion reactions. So this is important because during pregnancy, especially during pregnancy, because Rh incompatibility can lead to hemolytic disease of the newborn. So this slide over here talks about hemolytic transfusion reactions, which are medical emergencies. A hemolytic transfusion reaction occurs when you have incompatible blood is transfused. The recipient's antibodies attack the donor blood that they were receiving and causes hemolysis. This process will trigger inflammation, lead to organ damage, especially the kidney. It will cause acute kidney injury. Now, how do you know a patient is having a transfusion reaction? You're going to notice fever and chills, back or flank pain, tachycardia, hypotension, dyspnea, hemoglobinuria, and anxiety. And the most important nursing intervention when something like that starts happening in your patient in the first, and you usually notice this in the first 15 minutes. And that's the reason why when we give a blood transfusion to a patient, for the first 15 minutes, we check their vital signs before and 3 times during the process, and we monitor them for the first 15 minutes for any reactions. And if you see any of these signs and symptoms or any vital sign changes, the first thing that we do is we stop the transfusion. We keep that IV line open with normal saline. We notify the provider and the blood bank, and we monitor their vital signs. We assess the urine output because it can cause kidney injury, and so we want to make sure that didn't happen. And always verify. One of the biggest way to prevent this is to verify patient identification and blood compatibility carefully before initiating any transfusion. And to summarize, the hematologic system plays a major role in oxygen delivery, immunity, and clotting. Disorders of the system can lead to anemia, bleeding, clotting complications, infections, and malignancies. As a nurse, if you are in nursing school, it's important to recognize clinical manifestations, interpret lab values, and identify complications early. When reviewing hematologic disorders, always think about what is happening to the red blood cell, the white blood cell, platelets, and clotting factors, and how those changes can affect the patient clinically. And that is it for our lecture on the hematologic disorders.